Today we are together with Professor Abdul-Ghani. He's a professor in medicine and in diabetes division, Texas University. And we have some questions about diabetes for the new era of diabetes pharmacotherapy. And I would like to start with a question about insulin. Insulin was considered as the inevitable final destination for type 2 diabetes patients. Would you comment, does it change?
Yeah, of course. I mean, let's go back in history. Not long ago, about 20 years, other than sulfonylurea and metformin, we didn't have any tools to lower the blood sugar. And we know for sure lowering blood sugar is very important to treat people with diabetes because that prevents the eye, kidney, and nerve damages. So once you give your patient sulfonylurea and metformin, if his blood sugar remains high, you need to give him insulin because you have no alternative. Nowadays, when we have different other new classes of medications that work in different mechanisms, so we have enough tools, much more tools in our toolbox in order to well control blood sugar without the need of insulin. So I would say many of the people who many years ago we were giving them insulin, we will manage their blood sugar in a better way without insulin these days. And I assume some of those patients already taking insulin where they can control their blood sugar without the need of insulin.
Mm-hmm. Yes, and being a clinical pharmacologist, we are aware about patients might feel they are failed for the therapy when they initiate for insulin. They fear about.
Yeah, this is a psychological issue in people with diabetes because usually people with type 2 diabetes are started on pills and metformin and sulfonylurea, but when the disease advances, so they introduced insulin, but in parallel the complications develop. So they always associate the introduction of insulin with the development of complications, and that's a wrong association that the patients are making. And oftentimes, I tell patients you need insulin, so he said no, they don't resist even without knowing what is insulin and why is insulin, because once my mom took insulin, they amputated her feet, she had her heart attack, she died, all bad things start to happen. And that's why I'm explaining it's not because of insulin, it's just because she started too late, she waited too late to start the insulin and to prevent the complications. It's very important that we explain that to the patients always and educate them. And I want to say, yes, there are many patients who are taking insulin where we can manage without, but there is certain fraction of people with diabetes who without insulin, they cannot control their blood sugar. And those patients definitely should be taken insulin in order to control blood sugar, as I said, to minimize the complications of microvascular complications that we know for sure are coming from high blood sugar. These days, we shouldn't find any patient, there's no justification for having any patient who his blood sugar is not controlled, because we have enough tools without and with insulin to control his blood sugar.
Yeah, very helpful. And you mentioned that there are newer pharmacotherapies and newer ones, GLP-1 and some dual acting drugs. Would you comment for the future?
Yes, now these are several classes of new drugs that lower the blood sugar that work in a very different mechanisms. For example, what we call insulin resistance, or meaning the situation in which the insulin doesn't work properly in the body, that one of the major problems that leads to high blood sugar. Not only that, it's also associated with higher risk of cardiovascular disease, and I'll come back to that later. So insulin resistance is a major core defect, major problem in people with diabetes. Nowadays, in the past 20-25 years, we have a specific class of drugs that specifically improve the insulin sensitivity of individuals with type 2 diabetes. So we never had that before. So that's a class that does something that no other drugs are doing. And because, as I mentioned, insulin resistance is associated with higher risk of cardiovascular disease, once we give those drugs, in addition to controlling blood sugar, they also reduce the cardiovascular risk independent of lowering blood sugar. Same thing with the GLP-1s and the SGLT2s. So in addition to lowering the blood sugar and improving glucose control, they also reduce the risk of kidney and heart disease independent of lowering blood sugar. And those classes nowadays have become used by cardiologists and nephrologists, even in people without diabetes who have either heart failure or have chronic kidney disease.
You mean the off-label use or
it's
new
approved for
indications?
use.
Yes.
So for example, if a patient has heart failure, so the FDA has approved the use of SGLT2 inhibitors to treat heart failure even in the absence of diabetes. So that's an on-label, that's approved by the FDA, and it's illegal, and every cardiologist is using that. Same thing for kidney disease.
Evidence-based and approved.
Yes.
Yeah. And for the administration route, patients were fearing about this parenteral administration route, and there are some inhaled insulin forms.
Yes, the problem with insulin is it's so powerful in lowering the blood sugar that you need to control the dose properly. So therefore, if you overdose, meaning you give more insulin than needed, you can cause hypoglycemia, and that's a very unpleasant complication, and it also can cause a hyperglycemia or reactive hyperglycemia on itself. So therefore, controlling the dose is very important. So when you inject certain amount of insulin, you know what you injected is inside. But the problem when you give oral insulin, there has been some attempts to develop formulation of oral insulin or inhaled insulin. The absorption in the gut or in the lung is not guaranteed, and it depends on many other factors. For example, if you give inhaled insulin to a smoker versus somebody who doesn't smoke, the absorption will be very different. If somebody has a pulmonary disease like asthma or other things, so this is why you cannot control the dose accurately as much as you can do it when you give parenteral insulin. And in fact, there has been an oral insulin which was approved in 2006, Exubra its name, and it has all these limitations. And because of these limitations, even though it was approved by the FDA, the sales for this oral insulin didn't soar. And after a year, the company decided, Pfizer I think it was, to discontinue the production because it was not cost effective in terms of economics, even though it was effective in lowering the A1C. Now there's another insulin which is approved for oral administration. Last year was approved by the FDA, that they solved some of the technical issues that were present with the Exubra, but still not very commonly used to lower blood sugar as an alternative way on administering insulin than the parenteral insulin.
Now we are at the Diabetes Research Center in Atlas University Hospital, and for diabetic patients, do you have any few suggestions for the patients?
My suggestion is this. First, control your blood sugar, no matter what the reason is. And we have enough tools in order to control blood sugar for all patients at all stages of the disease. Because diabetes, unlike many other chronic diseases, let's say blood pressure, it's a progressive disease, means it worsens with time. So if you are well controlled now, the treatment that you are receiving is likely to not be sufficient down the road, 2-3 years down the road, and your blood sugar is going to increase despite taking the same medication. It's not because the medication is not working, it's because your situation deteriorated, or actually your pancreas is secreting less insulin, therefore you need more medications. So control your blood sugar, stay in touch with your doctor. It's very important to prevent the complications of the eye, the kidney, and the nerves. Second thing, if you have other problems, let's say heart disease or kidney disease, nowadays, and your blood sugar is controlled, nowadays they are mandatory to add some other classes that I mentioned before, can lower the risk of kidney disease or heart disease or stroke, even independent of lowering the glucose. So it's mandatory to add these medications in people with well-controlled blood sugar. And oftentimes, I see it, I had patients who well-controlled blood sugar, and he has renal impairment, so I give him an SGLT2, and the primary care stop it. Why? Because it's not active in lowering the sugar. But I didn't give it to him to lower the sugar, but just to protect the kidney, or to protect the heart, or to reduce the risk of heart failure, or to protect recurrent stroke or TIA. So nowadays we have tools by glucose lowering agents that can reduce other complications of diabetes independent of lowering blood sugar. So even if you are well controlled and you have some of those complications, go back to your doctor, because he can offer you other tools to reduce the risk of complications. Because it's no good to be in dialysis if you damage your kidneys. If you have a heart attack or stroke, you can die out of that. And if you can reduce that risk, you can also reduce your risk of dying, and you also can improve the quality of your life by delaying dialysis, improving your heart failure, your heart conditions, and preventing another stroke or TIA.
And can the patients understand correctly? Our pharmacotherapy goal is not just regulating the blood glucose, also avoid the complications.
Exactly. I mean, the reason that we are treating diabetes is not because of blood sugar. Blood sugar of itself doesn't painful, you don't feel it. Oftentimes people are not aware of it. Many times people come to us to check with us, and we see their A1C is 8 or his blood sugar is 160, 180 for many years, and they don't know about it. So the treatment of the sugar itself is not a target. That's a tool to prevent the complications. Ultimately, we treat people with diabetes to prevent the complications. And as I said, there are two types of complications. There are complications that are a result of high blood sugar in the eye, in the kidney, and the nerves. But even those who develop eye disease and go blind, you cannot die of that. People with diabetes are dying from heart attack and stroke. And that's what we need to prevent. And as I said, we have now tools. In addition to controlling blood sugar and controlling lipids, we have tools by using glucose lowering drugs that can reduce the risk of heart attack and stroke and heart failure independent of lowering glucose. Therefore, patients who are at risk for these complications, it's mandatory to take these medications even though if they have well-controlled blood sugar.
Thank you for your contribution. Would you like to add something more? Or?
Well, I'm glad to be here. I'm glad to work with doctors and investigators in Atlas University. And it's also very important, what I want to add is usually most of the research is done in the US and Europe. But what we learn, and especially in diabetes, that not everything is made in America is applicable anywhere else in the world. And I just give a very good example for GLP-1 receptor agonists, that when they tried them in Chinese and Asian population, it turned out that the sensitivity of the population is very different. So it's very important also to do studies here in the Middle East, in Turkey and other regions, to confirm or to find what are the needs for our own diabetic patients in order to treat them in a most proper way that fits their needs, and not just take everything done in America and replicate it in Turkey. Not always it's exactly what our patients are taking.
We are planning for future international collaborations for both local and global research on diabetes.